Okay. What we will discuss today is, suppose, see, the problem is many times the video doesn't get over in the last one. For the last time, from we have to discuss from MCQ 43. That is, dengue vaccine is the main point, which we will some MCQs we will discuss, and then we will go from slide 50, which is the catch-up immunization. We went up to catch-up immunization up to rotavirus, and from rotavirus onwards, we will start what is the problem of catch-up immunization. This catch-up immunization, surprisingly, is not being asked in the examination. When I discussed with Dr. Amal, it was really surprising for me because for us, when we went to the examination, there would usually be a oral, there will be a paper written, 6-year-old child unimmunized, write the immunization down when they are interviewing the previous candidate. When you go in, you give your paper, and then they will start asking questions from that. Somehow that they are more interested in asking MRI and EEG and all those things. Good to ask them, but this is very important. And you will realize whenever you have to do an write a catch-up immunization, for some one reason or the other, it's not that easy. Okay, now you start reading. See the questions, and now onwards, I'll put the questions which are coming practically from that. That's what is more interesting. As far as immunization went, I went into the depth because I want you, if you don't know immunization, you are not a pediatrician. But the questions that has been asked, once a dengue vaccine has been asked for a 5-mark question. Future vaccines have been asked again for a 5-mark question. What are the techniques you should know is look at the number of marks, number of minutes available, and then write your answer accordingly. That you should know, develop that habit. If you are asked future vaccine, that will include so many vaccine, malaria vaccine, the streptococcal vaccine, Ebola vaccine, everything. But dengue and malaria will be the major thing. Therefore, you should know how to, therefore the headings are important. What you write under it, you must be able to quickly adjust, etc. Therefore, Ashwati, you have joined. Unmute and talk, please. Ashwati is there. Hello. Anybody can say, Gopika, can you answer? Please unmute. I can't hear you. Can you hear me?
Sir, all children in endemic areas.
Who's reading this? Majida? What happened to Ashwati and others? Okay, read it now. Okay.
Dengue vaccine COVID TDV is recommended only for.
Yeah, you didn't attend the presentation. All children in endemic. Read it. Read the ABCD.
The options are A, all children in endemic areas, B, seronegative individuals, C, seropositive individuals with prior dengue infection, and D, travelers only.
What is the answer? Gopika, can you answer? Yes.
Seropositive individuals.
Yeah. Actually, this dengue vaccine as well as to the next 2 vaccines are now available. One is they are all, none of them are available in India, but it's a very important vaccine because dengue is a very important killer, especially in tribal areas, even in Trivandrum when epidemics occur. When I came in 2017-18, there are a lot of cases. It's supposed to occur once in 5 years. We can expect it any time now. Do you have dengue now in the ward? Hello, Majida, do you have dengue?
Last week.
Last week you had. Anyway, therefore, to have a vaccine is a good thing. But the funny thing about dengue vaccine is you give it to seropositive individuals. That means already the patient had one attack of dengue fever. Then only you can give. It's a very funny situation. Therefore, we will go into that later. The WHO recommended that. Can you read it fast?
The WHO recommended that only persons with evidence of a past dengue infection should be vaccinated.
Okay, what's the next question? The other vaccine is known as, the previous one was known as Dengue Vaccine. The second, this is a trade name. The second is known as Qdenga, maybe quadruple dengue. That's what it is. TAC03. Okay.
Mm. Qdenga is options are inactivated vaccine, B recombinant protein vaccine, C live attenuated tetravalent vaccine, and D mRNA vaccine.
Majida, anyway, any idea you were in Thailand when you took the class? So, Gopika, can you answer for her?
Live attenuated
Yeah,
tetravalent
both of
vaccine.
this are live attenuated tetravalent vaccine. Okay, both are live letter. The answer has come up now. Now we'll go to our next question. We read out what is in the bracket. Dr. Majida. Majida, read it out.
There are currently two licensed dengue vaccines, CYD TDV, Dengue Vaccine, Sanofi, and TAC003, Qdenga, Takeda. Both are tetravalent live attenuated vaccines but differ in the extent of chimerization and the genome backbone as well as in efficacy and safety.
Oh, what? I don't know. You read chimerization. I would have read chimerization. I don't know what is the right one. What does it mean? What does chimerization means? It's a mixture of genes of two different. That's what called chimerization. Gopika, what you wanted to say?
Nothing, sir.
Okay. Now we'll go to the next. Read what is given in the bracket, Majid.
Immunity induced by the primary infection is believed to induce lifelong protection against the infecting serotype, that is homotypic protection. In contrast, the cross protection afforded against other serotypes, which is heterotypic protection, lasts on average several months to 3 years. However, beyond this grace period of waning cross protection, there is an increasing risk that severe disease will result from a secondary heterologous infection, that is, infection by a different dengue serotype to that which caused the primary infection.
There's something very unique to dengue vaccine. What happens is the commonest, I think, is dengue. There's serotype 1. I think they're up to serotype 4. You get a dengue. The second type of, if you have a patient who has dengue and then he comes to ER and says, I had a dengue 2 years ago, this is my second attack, you might in other infectious diseases feel he will be less severe because he'll be immune. No, it's not like that. The second attack is usually more serious than the first attack because he has a different type of virus, different strain of virus, what they call serotype, different serotype, and therefore, yeah, when you have an infection with a different serotype, the result in a more serious disease. Therefore, if you have a child with you give an immunization, it acts as the first dengue. It produces homotypic protection, but against the other viruses, the immunity does not last long. And afterwards, a second infection, first infection after an immunization will cause a more severe disease. Read it again. Yes, go through it.
Compared with vaccination of seropositive individuals, vaccination of seronegative individuals result in the production of lower level of antibodies and a higher risk of severe disease in those who go on to contract the disease. The plausible hypothesis proposed for this is that vaccination primes the immune system like natural infection, and that after a period of protection following vaccination, immunity wanes and among seronegative individuals. The response to the first natural infection following vaccination and waning immunity may act as a second infection, which has typically been associated with a higher risk of serious disease.
Therefore, this is something which you should understand. I found it difficult to swallow that when you have the first infection, you to give it to us. Normally, we give it to patients who are seronegative. vaccination is given like that. In dengue, it's not like that because there are 4 serotypes. You give the first infection, the second infection is more serious because it's this second infection by another serotype produces immunity more serious. This remember that here I want to point out one thing. This is explained well, not in the purple book, but in the PG tips of 2023 IAP Kerala Accidental Plan. That's why you should read everything to get a clear idea about a subject. Okay, read it.
This increased disease risk of secondary infection is linked to non-neutralizing enhancing antibodies that facilitate virus uptake through FCM receptors by a mechanism known as antibody-dependent enhancement, or to a detrimental inflammatory or biased T cell response. During a secondary heterologous infection, memory B cell responses not only preferentially recall serotype-specific responses against the serotype responsible for the primary infection, but also boost and further induce the production of cross-reactive antibodies. This result in more efficient cross protection against subsequent, that is tertiary or quaternary infections, which are then less likely to be severe regardless of the infecting type. So, a protective vaccine should preferably induce an optimum immune response comparable in level and quality to that induced by a secondary dengue infection, which results in more efficient cross protection against a subsequent infection with all dengue serotypes.
Beautifully explained. Actually, this is so well not explained. If you just want to say that the is linked to what you should say is that the essence of it, why it's difficult to explain why should a secondary the primary dengue vaccine to a seronegative is more dangerous is because the increased risk of, let me begin with, the non-neutralizing enhancing antibodies. That's the mechanism facilitate the virus uptake, the antibody dependent enhancement, and to a detrimental effect of inflammatory basis. Therefore, this antibody dependent enhancement is the reason for this. You can read through it. Maybe so much details are need not be known. Maximum you expect is a short note on dengue. You can, but if you explain this, it will be very nice. Okay, you can go back to a slide and okay, now read through it again.
This optimal immune response should not only include neutralizing antibody against different serotypes, with both specific and cross-reactive neutralizing antibodies being produced at high enough levels and affinities to be effective, but also induce the production of moderate level of pro-inflammatory cytokines, type 1 interferons, chemokines, and cytokines that link the innate and adaptive immune responses. Similarly, at the T cell level, a vaccine should induce serotype-specific CD4 plus T cell and or CD8 plus T cell responses directed against both structural and non-structural antigens with no overt inflammatory profile. In seropositive individuals, the response to the first natural infection following vaccination is as if it was a third or later infection and not associated with a higher risk of serious disease. So, administration of vaccine in seropositive individuals mimics an attenuated and subclinical secondary infection with a heterotypic dengue serotype, so that subsequent infections would correspond to tertiary or quaternary exposures, which are less likely to be severe.
This is the best explanation that they are given. They are given in the PG tips and presidential action plan. I am not going to reread it. If you can understand it, it's very good. Okay, now next question.
Who recommends tag
It's not who,
003 for
WHO. WHO recommends.
sorry. WHO recommends tag 003 for children aged.
Okay. Gopika, can you say? Read the answer then.
WHO recommends tag 003 in children aged 6 to 16 years.
Okay. Read it now. Read the whole thing.
WHO said that it had cleared Takeda Pharmaceuticals vaccine. Takeda's vaccine, given in 2 doses over a 3-month interval, protects against 4 serotypes of the dengue virus. It was cleared by WHO for use in children aged 6 to 16 in areas with high infection rates. The pre-qualification makes it eligible for procurement by United Nations agencies like UNICEF and Pan American Health Organization. The short branded Quidanga is already approved in countries like Indonesia, Thailand, Argentina, Brazil, and was also authorized in the European Union in 2022.
Now, this what is given here is what is will help you in writing a short note about it. We had 2 vaccines, live attenuated. I will tell you the points. Live attenuated vaccine. You have the dengue varix and as well as the Codringa Takeda vaccine. Now, Takeda, WHO is more interested in Takeda after having giving a big talk of dengue virus. They are not very keen on the first vaccine because you can't do a what you call as a mass immunization with it because you don't know whether the child is seronegative, seropositive. But remember that 2 doses, 3 months interval, that's a very important point. Live attenuated vaccine, important point. It has been pre-qualified. This pre-qualification is the process by which the WHO takes experts from all fields, immunology, epidemiology, vaccinology, everywhere, and says that this is a vaccine which can be, there were normally countries would include it in their national immunization program only when it is pre-qualified. But it is not so in India. PCV14 is not pre-qualified. Many other, it is not a must, it's not a law in a country that it should be pre-qualified. Anju, you have joined, I think. Welcome. Okay.
Yes, sir. Yes, sir. Yes, sir.
Okay, therefore it is not, the pre-qualification is not a must, but this is published in 2000. In 2024, I found a Reuters in English and dengue vaccine clears dengue vaccine all over the world, but it's not clear. Now, read next edit. Can you read it?
Booster dose for TAC 003 is currently option A recommended after 1 year, not recommended due to lack of data. C required every 3 years, and D given with second dose.
Gopika, can you answer if you have gone through it?
Not recommended.
Yeah, not recommended. A booster is not recommended. Because these are points you can write in a short note. Okay, now read it.
The use of pre-vaccination screening strategy to limit vaccination to seropositive persons is not recommended in settings with high dengue transmission, as this would substantially reduce the public health impact of vaccination and increase programmatic cost. The target age group recommends the use of TAC 003 in children aged 6 to 16 years in settings with high dengue transmission intensity. Within this age range, the vaccine should optimally be initiated about 1 to 2 years before the age-specific peak incidence of dengue-related hospital admissions, although programmatic alignment with the administration of the other school-based vaccination and health intervention is also an important consideration. Catch-up vaccination can also be considered for other age group within the 6 to 16-year age range at the time of vaccine introduction.
Okay. Read it. Can you read it?
The vaccination vaccine is recommended as a 2-dose schedule with a minimum interval of 3 months between doses. It is not advised to reduce the interval between doses. If the second dose is delayed for any reason, it is not necessary to restart the series, and the second dose should be administered at the first available opportunity. Booster doses. Waning of vaccine efficacy was observed over the 5-year trial period. There are currently no data on the use of booster doses. Additional studies are underway to determine the use of a booster dose and its optimal timing. Accordingly, a booster dose is not recommended.
Okay. Can you say this? What's the answer? Has the slide changed for you?
Yes, sir.
Read it.
Tax 003 can be co-administered with
Gopika, do you have any idea what it is?
Sir, yellow fever.
It is yellow fever. Available evidence supposed with can be co-administered with yellow fever and hepatitis A vaccine. Co-administration, can you read it now? I'm going through it rather fast because dengue vaccine maximum will be a short note for 9 minutes. We will summarize to know in the depth of a dengue vaccine is not our job because we are not administering it. Can you read it now?
co-administration. Available evidence supports co-administration of tax 003 with yellow fever and hepatitis A vaccines. Studies to assess co-administration with HPV vaccines are ongoing. Inferring from co-administration studies of other vaccines, tax 003 may be co-administered with other inactivated subunit or mRNA vaccines, except for live vaccines for which more data are required.
They may be co-administered in inactivate subunit mRNA except for the live vaccine. Okay. What is this? Majida, can you read it?
Tax 003 is contraindicated.
If you had used your brain, you can do it because both the vaccines are live attenuated vaccines. Some of the things you should use your knowledge to do. It's contraindicated in children with congenital and acquired immunodeficiency. But it is contraindicated in breastfeeding also. That's a funny thing. But anyway, if you read through the contraindication, you will find breastfeeding is also there. Now you read it. Okay.
Special settings and populations. Pregnant and lactating persons, tax 003 is not recommended during pregnancy, and pregnancy should be avoided for at least 1 month following vaccination. Inadvertent vaccination of pregnant person is not a reason to terminate the pregnancy. It is unknown whether tax 003 is excreted in human milk immediately after administration. A risk to newborn infants cannot be excluded. Until such data becomes available, the vaccine is contraindicated for mothers during breastfeeding. Immunocompromised persons, TAG 003 is a live attenuated vaccine, hence it is contraindicated in persons with congenital or acquired immune deficiency.
Which are the vaccines? See, normally there are hardly any contraindication during breastfeeding for vaccination. Which other vaccine is contraindicated in breastfeeding? We discussed this in the last meeting. Gopika, can you answer? Gopika, you are there or not there? You're there. Unmute and answer. Which other vaccine? We had discussed it in the previous session. Can you hear me?
Yes, sir.
Yellow fever. We said yellow fever causes meningoencephalitis and sometimes has been reported. Therefore, remember that contraindication to breastfeeding is all absolutely zero. If you go for BFHI, I understood that you had a big session on BFHI and all that. I would ask you a question at the end of my answer, but they don't like any contraindication. I told you that chemotherapeutic drugs taken by the mother is a contraindication. Very, very unlikely that a mother on cancer treatment will be having milk to give to the child. The other contraindication is anti-thyroid drugs, carbimazole, methimazole also, I think. Maybe methimazole can be given, carbimazole cannot be. Therefore, there is two contraindications. I was surprised to find that two vaccinations also enter into it. One is yellow fever, and now they say tax 003 because studies have not been done. That is why studies have not. It's a new vaccine, therefore they don't advise it. Can you say it? Now the
For
other.
travelers,
Yeah, go ahead. Yeah.
For travelers, tag 003 offers the highest benefit when mm,
Can you say, Gopika?
Sir, it's a
Yeah, can you read it? Because this is something you can ask. You travel to Thailand. Thailand is one area very high in malaria as well as dengue, if I'm sure. Therefore, the question will rise, should I take it or not? It never crossed your mind, but just read the answer, please.
the highest benefit with the lowest risk is during an ongoing epidemic due to Dengue 2 or Dengue 1 at the destination.
We read the whole thing, but something is bracketed that also is important. Read the whole thing.
Travelers need to be informed that the vaccine may not confer protection against Dengue 3 and Dengue 4 if they are seronegative, and that there is a potential risk of severe dengue if seronegative individuals are exposed to Dengue 3 and Dengue 4. Travelers also needs to be informed that transmission of dengue is heterogeneous within countries and the circulating serotypes may vary during different periods. The highest benefit with the
Within countries. You can't see it.
The highest benefit with the lowest risk is during an ongoing epidemic due to Dengue 2 or Dengue 1 at the destination. Although pre-vaccination screening to determine zero status is not required, where available, its use could be considered to inform the assessment of risk and benefits.
Yeah. Therefore, if you are a very careful person, you want to travel to a place where a dengue, you can do, I don't know whether they do the antibody level, it will be worth it. Similarly, you can do the antibody level to chickenpox and mumps, etc., and decide to take the vaccine accordingly. Therefore, travelers is the other thing. Therefore, this is something that if there is an epidemic going about, say, you are going to travel to Tripura or you're going to travel to a tribal area where dengue is more fierce and there's an epidemic going on, then they may definitely it will benefit you. But if you are seronegative, you may have the opposite effect of it. That's a problem with the dengue vaccine. Now, the next question is, yeah.
Protection after first dose of TAC 003 starts.
We have seen that. Okay, now it's a difficult question to answer. You read it.
The protection starts 14 days after the first dose and has been demonstrated between the first and second dose.
Normally, the immunization, when you give a vaccine, it starts climbing up very fast after 7 days. The peak happens only on the 30th day on the primary vaccination. Now, dengue is a live vaccine. They say from 14th day onwards, you can expect protection. Why is it important? You should give, if you are giving to a traveler, you should give at least 2 weeks before. Now read this.
Protection starts 14 days after the first dose and has been demonstrated between the first and second dose. Hence, the first dose can be given up to 14 days before travel to a dengue endemic country. To ensure the durability of the protection, a second dose is needed after a minimum interval of 3 months. Until more data become available on efficacy safety profiles, WHO recommends a lower age limit of 6 years and an upper limit of 60 years for travelers. Health workers generally not at greater risk of dengue. All healthcare workers should be up to date with vaccination as recommended in their national immunization schedules.
The very funny thing. I don't understand why health workers are not at a greater risk, especially if they are going into the villages inside. Well, therefore, now this ends the discussion on dengue. The reason why it is one of the modern, therefore, if you are asked about future vaccine, that is one thing. This and malaria, you can concentrate on. The others, the theory we have discussed, we are not the MCQ. Now, if you are asked to summarize, suppose you have to write for 9 minutes, I would summarize what dengue fever is. You can write there are two vaccines available. Both of them are not available in India right now. They are live attenuated vaccines. And you must know the name Dengue Vaccine and TAC something. I don't remember the name. Actually, these are trade names. And then you should write that the dengue virus can be given only for patients who are sero positive. If you give it to zero negative, it may have more side effects than good. Therefore, the only choice to you is to either do a antibody level or give it to people who have already suffered one attack of dengue vaccine, dengue virus. This is because of antibody-mediated enhancement. That happens to infection, because if a patient is getting dengue virus 1, homotropic antibodies, and then the other antibodies may not wane off, and then subsequent infection may produce a more serious type of dengue 3 or dengue 4. Because of this, they have lost interest in this. WHO has lost much interest in this, and now they are interested in tag 003. But nowhere it is written. Let me tell you one thing, that tag 003 can be given to patients who are seronegative. They have not written it that way, but they have written that evidence for the first vaccine was most reactions were on seronegative. Therefore, now WHO is concentrating on tag 003. Does it mean that it can be given to seronegative individuals? It's not so sure. Now, point number one, the dose. It is to be given at 6 years to 16 years. It can be given up to 60 years for travelers. And you have to give a second dose. 2 live attenuated vaccine can be given at an interval of 4 months. But here they say you should give it only at an interval of three months. I mean, it can be given at an interval of 4 weeks, 1 month, normally, basic immunology. But here they say you give it only with a minimum interval of 3 months. Why they do that is probably all the studies would have been done only with that time. And you should also say that it is, since evidence is not there, it's better not to give for pregnant women and lactating mothers. And finally, for travelers, it should be given 14 days before they travel, and they should be told that it should not, it may, if you are negative, you may have a more severe infection. Therefore, it is better to do the serology and then give before 14 days and inform them that it doesn't protect against dengue 3 and 4, and they may still get an infection. Therefore, these are the points. I think with this, you will be able to write a 5-mark or a 9-mark short note on the dengue if it comes in the exam. Now we will go back into which last time we were discussing about catch-up immunization. And today we will start with rotavirus. Therefore, I will ask Gopika a very straight question. Up to what age you give Gopika? What is the immunization schedule of rotavirus? Can you tell me? Hello?
So till 2 years, we can give rotavirus.
Till 2 years you can give. Majida, what do you say? You are here, you are a DNB student. Huh? Remember that. You have to be above others. What happened to Ashwati? She came and she left forever, I think. I don't know. If I do it at 2 o'clock, 3 o'clock, you say you have calls. If you call it at 7 o'clock, you have calls at home. So we have to do it at midnight, I think. Can you tell me, Majid, at what time you can, till what age you can give? Anju, what's your opinion? Till what age you give in
റോട്ടയാണോ സാറേ?
rota.
സാറേ ഹോണസ്റ്റ് ആയിട്ട് പറയുകയാണെങ്കിൽ എനിക്ക് നോക്കിയാലേ പറയാൻ പറ്റുള്ളൂ സാറേ. കാരണം അത് ട്രെയിനിങ്ങിന് സമയം പിന്നെ പറഞ്ഞു, പിന്നെ അതിനുശേഷം ഓരോ ട്രെയിനിങ്ങിന് ഇങ്ങനെ പലതും പറയുന്ന കാരണം
Anju,
നമുക്കൊരു
please
ഇതില്ല.
talk in
ഈ
English.
1.5 വയസ്സ്.
Please talk in English because it's getting.
Oh, sorry, sir. Sir, honestly speaking, I am exactly sure actually. The point I understand is that till 1 year it can be given, but if the vaccination is started later, I think it should be completed within 1.5 years or something like that. I am not exactly sure, sir.
You're not giving it in your place now?
Yeah, routine vaccination is being given
Then you should
along
do-
with the 16 and 14 weeks and all. But there are some children who miss these and we start late. In those children, we actually, the last dose, we extend a bit after 1 year. I think it is before 1.5 years or something, we should complete the last dose and all. Otherwise, more than 1 year, it is not being given. I'm sorry, I'm not exactly sure. I'll have to refer for a correct
Yeah,
answer. Sir.
okay.
Sorry.
Now this is what I say, my sincere advice to all pediatrician is don't listen to what is given, what I am telling now. Look up whatever vaccine you give, open up and look at it and see it till what age it can be given. And give only up to that age. Why? It will come up in the following thing. You cannot depend on what the IAP says, what the WHO says, what I say. If it is written in black and white in that vaccine, what you call that leaflet along with it, the maximum age is 8 months or 6 months, and you give it 9 months. You have because ultimately they would say what is given in the paper, what is given at the leaflet along with that. Anyway, I'm a little surprised that yes,
Can
Anju.
I, sir?
Yes.
Can I add one word?
Yeah.
Because usually in health services, I have found that we are taking in, information from teachers like sir, and we do routine training done by Kerala as well as India. But when the final question, some query comes, it is usually very common to ask the immunization officer concerned in the district and all, because they are the persons who directly tell the JPH and all, according to the availability of the vaccine and all those things, what exactly should be done. So even if the exact the information should be can be different, which is given during routine training and all, we take the final word from such a senior who is concerned with these things. That point is also there, sir. That is applicable only in health service. Just mentioning only, sir. Thank you.
One thing for which I am doing this immunization in so much detail is there are many medical legal aspects to it. Okay. Now, when you go for an inquiry, I have never gone, but I've seen my own friends who were very intelligent, they go up for an inquiry. There'll be the director of medical education, there'll be the medical director, there will be the one person from pediatrics who will be there. And you go there and say that Dr. Padmanabhan said like this, or the WHO officer said, the commonest question which they ask immediately is, Doctor, you are a consultant pediatrician. On what basis did you do this? And they will throw the paper to you and say, how do you? Therefore, according to me, the best protection is, if there is a guideline by WHO position paper, you are certain, you are protected. If IAP has said something, there's a little less but definite protection. If there's a national guideline, finished, you are protected. National guideline, nobody can oppose. Even if it is outdated and old, you are protected. But Dr. Padmanabhan telling, or the WHO officer telling, the immunization officer, are all verbatim. On what basis, the original source, you should be able to say. That will become clear when you give rotavirus. What's the problem in rotavirus upper age limit? Dr. Anju, can you, sorry, Dr. Gopika, what's the problem with, we are so much bothered about the age limit of immunization of rotavirus. Why is it? Before I begin the discussion on this, I want to carry on. Gopika, are you there?
Yes, sir.
Why we are very concerned? There's a very much regarding rotavirus, there is always a problem. There's a big
The risk of interception.
Risk of interception.
Yeah, Rotashield, the first vaccine which came about, there was a risk of a higher incidence of interception. And there are pediatricians. There's a group of pediatricians from Delhi. I don't want to name the name. He's a Malayali doctor who's dead against giving it. He says that this causes our rotavirus also cause interception. What is the present view is, what about rotavirus and interception? What's the present view? Dr. Gopika, can you tell me? I should be asking Majida also, but she's just second year. Okay. Gopika, can you answer? What's the second reason why? What's the present view regarding it? The present view is that normally intersusception occurs at the period of weaning, 6 months, 8 months. That's the time at which you are giving the rotavirus, and therefore you found out that there was a association by timeline observation, but it was not above that. But later on they found it was, and the original, this was withdrawn. That is Rota Shield was the first one which came. It was withdrawn. Rotavirus was not given. But rotavirus diarrhea is the most common cause of acute viral diarrhea, the major cause of mortality among gastroenteritis. And therefore, it was reintroduced with lot of caution. Now let's go through it. Okay, read it. Majida, can you read it?
Sir, I will read it.
Yeah, okay.
Rotavirus, a pentavalent human bovine reassortant rotavirus vaccine. The manufacturer's recommended schedule is 3 oral doses given 4 to 10 weeks apart, beginning at 6 to 12 weeks of age. The series should be completed by the age of 32 weeks. Rotarix, a monovalent human rotavirus vaccine. The manufacturer's recommended schedule is 2 oral doses given 4 weeks apart, beginning at 6 weeks of age. The series should be given before 16 weeks of age, but must be completed by the age of 24 weeks. Rotavac, a monovalent human bovine reassortant rotavirus vaccine in the form of frozen liquid. The manufacturer's recommended schedule is 3 oral doses given 4 weeks apart, beginning at 6 weeks of age. The series should be completed before the age of 8 months. Rotacil, a pentavalent human bovine reassortant rotavirus vaccine in lyophilized or liquid form. The manufacturer's recommended schedule is 3 oral doses given 4 weeks apart, beginning at 6 weeks of age. The series should be completed during the first year of life.
Okay, now remember Rotacil, they have written first year of life in the WHO position paper. Remember this, okay? All others are well above it. Rotavac is 8 months and Rotarix is 24 weeks. That means it's 6 months. And Rotatec is 8 months. Therefore, if you are giving Rotatec or Rotarix or Rotavac, follow what is written in this one. If you are giving Rotacil, which is manufactured, I think, by Serum Institute of India, you can give up to 1 year. But remember the next thing. Read this.
Schedule in universal immunization program, the rotavirus vaccine is to be administered in 3 doses at 6, 10, and 14 weeks, along with the other UIP vaccines. The maximum upper age limit for giving first dose of rotavirus vaccine is 1 year. If the child has received first dose of rotavirus vaccine by 12 months of age, 2 more doses of vaccine should be given with an interval of 4 weeks between the 2 doses to complete the course.
Okay, if a child rotavirus by 2 more, therefore if you have given by 11 months and 6 months, you can give about 12 months, but you cannot start a vaccine about 12 months. That's what it is. And that too, what it is to be administered, scheduled in the universal immunization program. It is a Rotacil. It is not Rotatec or Rotarix. Understood? That must be clear. Now see what is happening in, I hope it came up. If you look at here, 6 weeks and 14 weeks can be given till 1 year of age. Okay, clear. Rotavirus, this is the national immunization schedule for children and pregnant women. Surprisingly, I couldn't get the date. They should put the date very clearly in that, but this is what I got in the latest. And therefore, don't give above 1 year. Okay, now, again, it's not the end of the story.
If a child less than 24 months of age misses a rotavirus vaccine or series for any reason, WHO recommends rotavirus vaccine for that child. Because of the typical age distribution of rotavirus vaccine, RVGE, rotavirus vaccination of children more than 24 months of age is not recommended.
Okay, read it.
The WHO recommended upper age limit for rotavirus vaccination is higher than the age restrictions indicated in the product information for Rotarix, Rotatec, and Rotavac, and thus constitutes an off-label recommendation for these products.
Therefore, if you are given to a 1.5-year-old child, don't be panic. Say, I am following the WHO position paper, because the WHO position paper in July 2021 has given that up to 24 months it can be given. This is more authentic than what anybody would tell you, whether I tell or Dr. Shija says or the WHO representative says. What is told in IAP meetings have no value as far as this is concerned. Therefore, remember that the upper age limit is better. If you are giving Rotavirus, it's better to give up to 1 year. You can give in the public. Therefore, if age or 9 months or 8 months or 9 months child comes in PRS hospital, give Rotavirus. Otherwise, strictly follow what is given in Rotatech and Rotarix leaflet. Don't say that I'm going to give Rotarix at 1.5 years because WHO said. WHO is talking about the vaccine that is available in the UIP program, probably. That's my advice to you. Now, if you look at IAP, look at what the IAP has done. See, you must see this charts which you see has got tremendous importance. This is the recommended age. That means 6, 10, and 14 weeks. Green is the catch-up age. They have given only up to 9.5 months or 10 months, maybe 10. Not at 12 months. 12 months starts here. Therefore, probably they are given only up to 9.5 months or something. White is not recommended. White is not come up here, but white means not recommended. Not recommended. Cream. Therefore, remember that your IAP, ACVIP registration, now it's given only up to 1 year. Remember, catch-up range. Catch-up range is 1 year. Be safe, give only up to 1 year. If you are by chance given to 1.5 year, going to an inquiry, throw up the WHO and says WHO has advised this. I don't know how many of your consultants would know this. If they are immunizing a child beyond age 6 months or 8 months, you should definitely not give Rotavirus or Rotatech. Immunization only up to 9.5 months. I don't think this is 9.5. Maybe it is 10 months. Remember this. Now, now this is rotavirus vaccination. Only catch-up immunization you read. Gopika.
The maximum age for the first dose in the series is 14 weeks, 6 days. Vaccination should not be initiated for infants aged 15 weeks, 0 days or older. The maximum age for the final dose in the series is 8 months, 0 days.
Okay, therefore they have written about Rotatech. That is, you should not start 14 weeks, 6 days. 15 weeks means it is 1 month and 2 weeks. Okay. 1 month is, 2 months is 8 weeks. I'm sorry, this is 3 months. Yeah, 3 months is 12 weeks and 3 months. You cannot give. Therefore, remember the first dose also when you can start the series is given. But according to Rotavirus, which is given by the IAP, you can start the dose before 12 months and then continue it afterwards. But if you are giving Rotavirus, remember, Rotavirix, remember this is the upper age. Rotatech, the last dose is given at 6 months. Therefore, it will be much earlier than the age. What is given here is actually, now comes the real position. Look at, this is up to date in July 2025. Bovine rotavirus RV5. RV5, I think, is Rotatech. Am I right? Rotatech is this. They have written recommended 2, 4, and 6 months, minimum age 6 weeks. Maximum age of first dose in United States is 14 weeks and 6 days. In Europe, it is 12 weeks. See how the difference is. There's all medical legal reasons. And if you are giving this, it is 2, and Rotarix is 2 dose only, 2, 4 weeks. Here also 14 weeks, 6 days. Europe, it is 12 weeks, same. And the last dose is given here 8 months in America and 6 months in Europe. But I thought this was 6 months was given before. So read what is given in the pamphlet. And if you look at rotavirus and the maximum age according to your Nelson's test book of pediatrics is 8 months, 0 days. Okay. Remember, that's what they have written like that. If above 8 months is not to be given. But what is important for us is what the IAP has said and what the WHO has said. We might give up to 1 year. But that too only for Rotavirus. We will not give for the other companies. Okay. For a 4-month-old child, as per IAP and international recommendation, cannot be started. As per UIP and WHO recommended 3 doses 4 weeks apart. Rotavirus. So we have already seen this. I think that's enough. Now, if you look at it, we have already seen this also, and I am putting it back to make you aware. But here it is given that it should be completed by 32 weeks, that is 8 months. And here it is Rotavirus is given as 24 weeks. Okay, 24 weeks is completed. Therefore, you should should be complete by 32 weeks here. Here should be started before 16 weeks, that is 4 months, and completed by 6 months. The Rotavirus in different places are given different. The Rotavirus you should complete by 24 weeks. You can't remember all this. Remember only 2 or 3 things. Up to first year Rotavirus, you can give up to 2 years. Therefore, if your colleague gives a Rotavirus at 1.5 years, don't blame him. This is why I want to say this. Don't blame one another. He's following the WHO. Now, if I ask you 11-month-old unimmunized child, what will be the rotavirus catch-up vaccination? Gopika, can you say that? Majida, can you say that? You listen to all this. Ashwati, you are there? Majida, you can answer. 11-month-old unimmunized child, you have unmuted. You answer now. You're answering or not answering? Gopika, can you
The
help?
Rotavirus
Rotavirus can be given up to
What
1 year.
What is it?
Rotavirus.
Okay. Rotavirus, you can give how many doses? 3 doses you can give. Okay. Now, Ashwati, you are there? No. Okay. Therefore, 11-month-old child, as per IAP and international recommendation, vaccination cannot be administered. As per UIP and WHO, 3 doses of Rotavirus 4 weeks apart can be given. Now it's a 15-month-old child unimmunized. What will you do?
No vaccinations can be given.
Yeah, as per IAP, UAP, and international recommendation cannot be given. As per WHO, 3 doses of 4 weeks apart, Rotavirus can be given. Because Rotavirus, as per WHO, you can give it up to 2 years, but don't give it. That's my answer to you. But if they come and insist, write their WHO recommendation. Okay. 25-month-old unimmunized child cannot be administered. Okay. Therefore, I hope that rotavirus fact is not. This is why I say catch-up immunization is not a joke. You can be in medical legal issues. You give a child 9-month-old rotavirus and he develops interception. He comes to the ER, somebody in the ER, somebody in the radiology, somebody in the pediatric surgery muts out to the relative. Oh, they gave immunization at 9 months. You had it. Now, if you go and say this is what the IAP has said, but if the leaflet of that particular vaccine says you cannot give this above 8 months, it will be difficult. The judge will decide on whichever way he goes. You are at their mercy. Better don't. But Rotavirus, definitely you can give. Let me tell you, these things happen at the highest level. When I was a student in DCH in Bombay, the greatest pediatrician at that time was S.M. Merchant in Bombay, and forget her name. There was one lady in Safdarjung Hospital, which she was considered the the biggest president of IAP and everything. Forget her name, I'll tell you. We were giving dexamethasone intrathecally as well as intra way by to all tuberculous meningitis. And to one patient who was the son of a judge in High Court and filed a case because it is written, use only IV and IM. All over India, people were giving it intrathecal. Therefore, when it came to the court, SM Merchant was, I understand, was the technical expert. And he actually had to support the other lady. He said, this I also give. The judge said, you giving does not justify. The pharmaceutical company said, we have never tested intrathecal. Finished. So remember carefully, medical legal matters very much. Now coming to the next. Can you read through it? Measles, mumps, and rubella.
Measles, mumps, and rubella vaccine, IAP, ACVIP. Routine vaccination, minimum age is 9 months. Administer the first dose of MMR vaccine at 9 months of age, second dose at 15 months, and third dose at age 4 through 6 years. Catch-up vaccination, ensure that all school-age children and adolescents have had 2 doses of MMR vaccine. The minimum interval between the 2 doses is 4 weeks. 1 dose if previously vaccinated with 1 dose. In campaign mode, MMR vaccine can be administered irrespective of the administration of previous doses.
This is something which is very difficult. If you have given 2 doses, why, or 3 doses, why give the 4th dose? Anyway, in campaign mode, that doesn't happen. And you know that during an epidemic of measles, what's the youngest age at which you can give measles vaccine?
6 months.
6 months you can give. In a normally hepatitis A is given at 15 months or 16 months. During an epidemic of hepatitis A, when can you give the lower stage at which you can give hepatitis A? Anyway, leave it. Now read MR vaccine.
MR vaccine, routine vaccination, universal immunization program. Dose 1 is administered at minimum age of 9 months or 360 completed days. Dose 2 is administered at 16 to 20.
16 to 24 months.
Catch-up vaccination. Catch-up vaccination up to 5 years. For catch-up vaccination, minimum interval between dose 1 and dose 2 should be at least 4 weeks. Measles-containing vaccine can be administered to infants aged 6 through 11 months during outbreaks. These children should be revaccinated with 2 doses of measles-containing vaccines, the first at ages 12 through 15 months and at least 4 weeks after the previous dose, and the second dose at ages 4 through 6 years.
Okay, therefore 3 doses we are giving. Anyway, the interval between 2 live vaccine is 4 months is enough. Surprisingly, in dengue, they are telling 3 months should be there. That's what I pointed out. And therefore, catch-up vaccination, you must know, can be given up to 5 years. Therefore, if you are asked 6-year-old child immunization, whether you will write measles is a question mark. Therefore, there you must know that carefully. Okay. Now we come to, okay, varicella vaccine. We read it.
For catch-up vaccination, children below the age of 13 years should receive 2 doses 3 months apart, and those aged 13 years or more should receive 2 doses at an interval of 4 to 8.
Okay, why is it given that above 13 years? Because there is an emergency in it. But below 13 years, they say you can wait for 3 months. Normally, live vaccine can be given within 4 weeks. At 4 weeks. Yeah, they are again telling 3 months. The further the dose, the more is the longer is the duration of protection. I think the same thing is given in 1 to 2 varicella. Yeah, 3 months given in Nelson. Okay, now we come to hepatitis A. Can you read it? Have you taken hepatitis? I may ask you a question. Have you taken hepatitis A vaccine? No. You don't take it, is it not? Okay, read it.
IAP, ACVIP recommendations for individual use. The hepatitis A vaccine may be offered to all healthy children. Special emphasis in risk group as enumerated below: patients with chronic liver disease, carriers of hepatitis B and hepatitis C, congenital or acquired immunodeficiency, transplant recipients, adolescents seronegative for HIV who are leaving home for residential schools, travelers to countries with high endemicity for hepatitis A.
Very important. See, you must know exactly what the IAP-ACVFT committee has recommended. May be offered to all healthy children, because when you offer like that, there's always a question that the government sector will say they are giving it for getting money. No, hepatitis A vaccine may be offered to all healthy children. We'll finish this, then I come to a discussion, okay?
IAP recommendations, hepatitis A vaccine schedule. Routine vaccination include inactivated vaccines more than 12 months, 2 doses administered IM at 0 and 6 to 18 months. Live vaccines more than 12 months, single dose administered subcutaneously. Then catch-up vaccination, inactivated vaccines, 2 doses administered IM at 0 and 6 to 18 months. Live vaccine, single dose administered subcu. For catch-up vaccination, pre-vaccination screening for hepatitis A antibodies recommended in children more than 10 years, as at this age the estimated seropositive rates exceeds 50%.
All right, for catch-up immunization screening is very important. If you have more than 10 years, it is better that they do a pre-vaccination screening. But if it is positive, you don't have to give it. But many times what happens is when our students, when they go to hostel, like IIT or NIT, Trichy Engineering College, etc., they ask for immunization of typhoid and hepatitis A. I would also strongly advise that if you have any relatives who are children or adolescents are going to college and going to the hostel for the first time, give them hepatitis A vaccine. If it is possible, do the screening, but don't. It is not necessary that you should do the antibody level, because hepatitis A is not that the commonest cause of acute, severe hepatitis causing coma is viral hepatitis A and not hepatitis B. Remember that. Hepatitis B is more likely to cause cirrhosis, more likely to cause carcinoma, etc. But hepatitis A is the one which causes hepatic coma and sudden acute hepatic failure, more likely. And many children, when they go to, but they are well protected when they are at home. But nowadays, most of the children eat outside also. But when they go to a hostel, it is totally different environment. The well may be a 5-star college, but the hostel will be Stone Age hostel with no proper hygiene. Read up it.
Since the cost of screening to identify those susceptible to hepatitis A infection is lower than the cost of the vaccine, IAP-ACVIP recommends pre-vaccination screening for hepatitis A antibody in children over 10 years of
age. All right. Now, therefore, this you must very clearly understand hepatitis A. Both, I think both inactivated and live vaccines are available. When I inquired in PRS, it was the inactivated vaccine, and live vaccine, single dose is required, but it can be given only after 12 months. It can't be given before that. And it is given subcutaneously. Anyway, can I ask Gopika, why is the live vaccine given subcutaneous and why the inactivated vaccine IM? MMR can be given subcutaneously. Can you tell me? Hello?
for longer onset of action, for mimicking a
No, it is not
natural
due to that. It's not due to that. Inactivated vaccine cannot be given subcutaneously because it does not contain dendritic cells and the blood vessels are less. The blood vessels are very high in the intramuscularly and the dendritic cells are more intradermally. Subcutaneous spaces, there are hardly any dendritic cells or blood vessels. Now, if you give a live vaccine subcutaneously, the virus will migrate to the lymph node and then produce an antibody level because it's live. If you give a dead vaccine, it is not going to migrate. Therefore, if it is not taken up by the blood vessel or the dendritic cells, it may not be effective. That's why you will find the route of administration, we discussed it. Anyway, even if you discuss, it doesn't seem to. Now, my question to you, typhoid vaccine, will you advise or will you not advise? What do you say? I think Anju left, I think. Anju, you are there or you are left? Ashwini, you are there or not there? Ashwini has simply logged in and left the place. Okay, Majida, do you have, should we be giving typhoid vaccine or not? Gopika,
Yes, sir.
what do you say, Gopika?
We should give, sir, because in our place there are so many cases.
Yeah. Actually, you are correct. WHO does say typhoid vaccine. Many people would say, is it necessary? Do you see typhoid now? Actually, in children, it is much less. 3 to 4 years, you don't get typhoid. And it is less than other. But in northern countries, you find typhoid is northern states, typhoid is much more common. The reason why WHO is insisting on it is because salmonella is becoming resistant to antibiotic, especially in Pakistan. The almost is resistant to all the antibiotics you can throw at it. It's a huge emergency there. Therefore, that is why more and more bacterial vaccines are being. The WHO is insisting on it. Now let's see what to say. Okay, there are two types of vaccine: polysaccharide and conjugated vaccine. And I think you better read the whole thing.
IAP recommendations, typhoid vaccine, both polysaccharide and conjugate vaccines are available. Minimum ages are type bar TCV 6 months, polysaccharide vaccine 2 years. Vaccination schedule for polysaccharide vaccine, single dose at 2 years, revaccination every 3 years. There is no evidence of hyporesponsiveness on repeated vaccination so far. For virulence polysaccharide conjugate, type bar TCV, single dose
Virus,
at 9 to 12 months.
Yeah, VI, I think is, what is VI?
It's given in the bottom line, virulence
Bracket.
polysaccharide.
Virulent polysaccharide, okay. Virulent polysaccharide conjugate vaccine, huh? Yeah, single dose 9 to 12. Yeah.
Catcher vaccination recommended throughout the adolescent period, that is till 18 years. IAP prefers the use of virulence polysaccharide conjugate vaccine.
Why does, if there is a conjugate vaccine, which is a single dose, 9 to 12 months, actually, some places they're given 6 months. Why the hell does you have a polysaccharide vaccine? Can you give me an age? Can you give me a reason for that? Because polysaccharide vaccines are always cheaper than the conjugate vaccine. Therefore, if a patient is not able to afford, you can give polysaccharide vaccine. But he must be at least 2 years old. And then you have to revaccinate every 3 years. Now, two questions I would like to ask you. You can give up to 18 years. They are saying that the catch-up period is 18 years. Suppose a 24-year-old patient comes, would you give or not give? I'm not too sure about it. You should give, I think. This question I always ask. I asked you previously also. Conjugate vaccine is a killed vaccine or a live vaccine, Gopika? Gopika, can you answer? Somebody else is answering. It's a killed vaccine. Now you mute it, Gopika. Majida, Faris, you have made a guest appearance. You are there.
Yes, sir.
Very good. Today's guest now. This typhoid is a killed vaccine or a live vaccine?
Killed.
Normally, killed vaccine, you give a single dose or multiple doses?
Single
Multiple
dose.
doses.
Multiple dose.
Multiple doses.
Then why are we giving a single dose, Gopika? This is what happens when you don't attend the class. You will pass out tomorrow as a doctor, pediatrician, everything. You go to some meeting or something, somebody can ask you this question. Why, doctor, typhoid vaccine, kill vaccine, only one dose? What's the answer to it? Simple. I have told this several times. It's not given anywhere, but somewhere I've read it. That's why I'm asking you. Because in your body, in your water and food, you are getting salmonella free from the government. Therefore, it is probably acting as a booster. Actually, initially, the typhoid vaccine, they said 2 doses, 8 weeks apart. Even they said 3 doses. Now they come down to single dose. And remember, this is IAP recommendation. Single dose of a killed vaccine. Remember this. You should go into it. Because somebody will suddenly ask you, how can you give a single dose? And you'll say, no, 2 doses. No, you must be able to tell with your hand down on the table. No, IAP says that. What is the reason they have not given here? But the reason they say is this has bound to be effective. How is it effective? They don't want to say. Because in developing countries, salmonella is present in the water and food, and it should be acting as a booster. Even people who have been given a single dose of conjugated polysaccharide vaccine seems to be effective. Now, above 18 years, will you give it is a question mark which you should ask yourself. Now we come to human papilloma virus. We have already said this. Are we giving it or not giving it? Majida, will you advise to a patient or not advise to a patient? Because why it becomes as a catch-up immunization is, it is you are giving for the first time, but it is given to older age children. Therefore, these all come up under catch-up as well as adolescent immunization, etc. Now, Majida, what do you know about human papilloma virus injection? Is it important? Is it being given in?
Yes, sir.
Yeah, yes. Carry on.
Yes, sir, it is important.
Is it being given by our consultants? Our doctors are giving it?
Yes, sir, they are recommending.
Recommending is.
Every patient whom you comes after 9 years, you should talk about it. And if you say no, you write it down. Don't pressurize it because it's a very costly vaccine. Therefore, now tell me all about about human papilloma virus. Why should it be given? Paris, you say that. The guest consultant should say that.
Really, against the cervical cancer.
Okay. How many doses? What age? Till what age you can give? What are the vaccines available?
Gardasil 9.
Gardasil 9. Okay.
Sir, Cervarix and Gardasil 4 and Gardasil 9.
Okay, Gopika, you're correct. How many doses you give? Remember, that's only one vaccine.
So can be given as 2 or 3 dose schedule, sir.
Yeah. Remember this, you always see a child has been under your care. You are given all immunization advice. You think I don't have to talk papilloma virus, they may not like it because it's not. It goes on to develop cervical cancer. They will never in their hearts believe you. I mean, they will never justify what you have done. They will never forgive you. Remember this. Therefore, there is a vaccine available. You have to talk to them. You have to know everything about it. It is not available in the hospital, in the universal immunization program, but IMA and others are bringing it about in a very low cost, in a very big way. They are conducting campaigns. The dose, I think they are giving free or very low cost, 1/5 of the cost of what is available in the market. And you should encourage your patients. Now read it now. Can you read the whole thing?
IAP recommendations. Routine vaccination in India, both 4-valent HPV and 9-valent HPV are currently available in India. Minimum age is 9 years. 9 to 14-year girls, 4-valent HPV and 9-valent HPV are recommended in 2-dose series with a minimum gap of 6 months between the doses. 9 to 14-year boys, nanovalent HPV is recommended in a 2-dose series with a minimum interval of 6 months between the doses, 0 to 6 months. 15 to 45 years girls and women, 3-dose schedule. Quadrivalent HPV 0, 2, and 6 months, and nanovalent HPV 0, 2, and 6 months till 26 years of age.
This is 26, the other is 45. Remember that, 4-valent. Yeah.
For immunocompromised individuals, 3-dose series is recommended. In a 2-dose schedule, the minimum interval between doses should not be less than 5 months. If the second dose is administered after a shorter interval, a third dose should be administered a minimum of 5 months after the first dose and a minimum of 12 weeks after the second dose. In a 3-dose schedule, the minimum interval between the dose 1 and 2 should not be less than 4 weeks. The minimum interval between dose 2 and 3 should not be less than 12 weeks. And the minimum interval between dose 1 and 3 should not be less than 5 months. If a vaccine dose is administered after a shorter interval, it should be re-administered after another minimum interval has elapsed since the most recent dose.
Remember that normally it is a killed vaccine. Human papilloma virus and it is currently available. They are not made it very clear. Therefore, you are giving in 2 doses below 15 years and 3 doses above 15 years. Why is it like that? Why do you start the vaccination at 9 years? The reason is you should give the vaccination before the first sexual contact. They were looking at Western countries and probably looking at India also now. 9 years is probably too early, probably for Kerala, but then I don't know. Therefore, that's the reason why 9 years is given. And 2 doses is enough before that. I don't know why 3 doses are required. Probably because they think that if the patient has already had a contact with the virus, then it requires a higher doses. Now, 0, 2, and 6 months is a classical indication for 6 years. Therefore, the interval between you should not give before 5 months. If you are given before 5 months from the first dose, then you will have to repeat it again. Therefore, this you should know very carefully in that. And now regarding catch-up administration, okay. Okay, can you read it?
Catch-up.
Yeah. I can't hear you, Gopi.
Catch-up vaccination. Administer the vaccine series to females, 4-valent HPV at age 13 through 45 years and 9-valent HPV till 26 years in females if not previously vaccinated. Use recommended routine dosing intervals for vaccine series catch-up.
Okay, therefore you should do the catch-up vaccination is only that much. Now, is there any difference in the WHO protocol? Mahajita, has anything new come up? You know what's the cost of a 9-valent HPV vaccine?
About 3,000.
9,000 rupees. What's the 4-valent is about 3,000 or 4,000, I think. You must go to the lab, to your immunization clinic and find out whatever we are talking, how much important it is, etc. Anju, do you give HPV vaccine in your practice? Anju, you are there? No. Okay. My question to you is, therefore, what does the WHO stand on this? When we took the class, remember I said about this previously. Why read this? Okay. WHO paper 2022. Therefore, this will not be even in the purple book. Remember, what is the importance? Yeah, it is in the purple book. But WHO position paper 2022, how it is there, I don't know. Okay, read it.
The vaccination schedule, two-dose schedule. The current evidence supports the recommendation that a two-dose schedule be used in the primary target group from 9 years of age and for all older age groups for which HPV vaccines are licensed. The minimum interval between first and second dose is 6 months. A 12-month schedule result in higher GMTs and is suggested for programmatic and efficiency reasons. There is no maximum recommended interval between doses, and longer intervals up to 3 to 5 years can be considered if useful from a program perspective.
Therefore, even at from 9 years of age to older age, now the WHO is giving two-dose schedule. GMT means geometrical mean titers, suggested by programmatic and efficiency reason. More maximum recommended interval is okay. Two-dose schedule is enough according to them. Actually, it has come somewhere above that. Okay, now read it.
Alternative single-dose schedule as an off-label option, a single-dose schedule can be used in girls and boys aged 9 to 20 years. Data from immunogenicity trials, post-HOC analysis of efficacy trials, and post-licensure observational studies among females have demonstrated that a single dose of HPV vaccine is sufficient to elicit an immune response that provides similar protection as a multi-dose regimen against initial and persistent HPV infection. This may offer program advantages, be more efficient and affordable, and contribute to improved coverage. From a public health perspective, the use of a single dose schedule can offer substantial benefits that outweigh the potential risk of a lower level of protection if efficacy wanes over time, although there is no current evidence of this.
Okay, now they may ask you, doctor, what do you think is why is the WHO talking about a single dose? Just to save cost? They may ask you. If I am the examiner, I would ask you, just to save cost? No, there is something called impact. You understand? What the WHO is interested, vaccine is introduced, what impact it has on the community. A single dose may have a major impact because more countries will choose the vaccination, and the decrease in the cervical cancer will be much more than when you advise 3 dose. If you advise 3 dose, definitely a very small percentage of the countries will be able to afford it. That is the reason. But anyway, you remember that WHO advises 2 dose. An off-label option of a single dose schedule can be used in girls and boys 9 to 20 years. Now, if you have a boy 9 years, and if you have a boy girl 9 years, you have only, the mother says, I have money only for one vaccine. Whom will you give? Can you tell me?
Boy.
Majida, you're preferring boy. You have a girl. It is the girl. It's a cervical cancer which has been proved beyond doubt. In fact, boys were never given. It was initially advised only for the females. Later on, they said those who are given this vaccine had less incidence of carcinoma penis, had less incidence of condylomata or something, and even HIV. I don't know, many things. They can't get carcinoma cervix. Therefore, definitely the real indication is for the girls, but later on they added probably the vaccines and they added it. Now we come to the Japanese encephalitis. Are we giving it here?
Yes, sir.
Okay, Japanese. Then is it advised by the? What is the advice? Okay.
In endemic areas, 4 districts, sir.
Okay. You read only the highlighted ones. JE, what's the IAP recommendations? What is highlighted?
Recommend only for individuals living in endemic districts. 2-dose schedule, first dose at 9 months along with MR vaccine, and second dose at 16 to 18 months along with DTP booster. Minimum age is 1 year. US FDA
sorry,
approved 2 months.
1 minute. I have to say something here. There are 2 types of vaccine. One is live attenuated cell culture vaccine, with the minimum age is 8 months and 2 doses. Okay. And the second is inactivated vaccine, biological minimum age is 1 year. 0 and 28 days, more than 1 to 2 years. Now they have written catch-up in all susceptible children up to 15 years should be administered during disease outbreak or ahead of anticipated outbreak. Now my question to you is it advised in Trivandrum district? Is it an endemic area?
Yes, sir.
It is, okay. I'm not too sure. This is the current immunization schedule, and you give, and they have written JE actually is vaccines given only in identified endemic districts of the country. That district should be, we are routinely giving it.
In government sector, it is routinely given, sir.
What about PRS hospital?
Not routinely given, sir.
Yeah, it can be a tremendous medical legal issue, is it not? Somebody develops a Japanese encephalitis, immunization PRS, we don't give it. It can, therefore you should know where you are practicing. You should be very clear whether it is a endemic area or non-endemic area. Now, if this is the national immunization program, subcutaneous because it's a viral vaccine introduced in select endemic areas after the campaign. That's it. Okay. Now, please find out whether Trivandrum district is a, Faris, what do you say? Is it a endemic area?
Sir, Trivandrum and Alappuzha, they are giving, sir.
They are giving, is it? Okay. In Tekad, they are giving, am I right?
Yes, sir, yes.
Okay. Now, somebody is calling for the mother desperately. Now we will go to quadrivalent meningococcal vaccine. Now, what's your opinion, Dr. Faris? Should we be giving or not giving my meningococcal vaccine? What are the points in favor? What's the points against it? Is it available under the universal immunization program? Any idea? Go bigger. Is it available under the universal immunization program? My God, I did something, it went. Where did it go? All right, is it available under the universal immunization program? Are you hearing me? Nobody's answering.
Why did we?
Majida, can you answer? Is it available under the Gopika's daughter is faster than her? Is it available? Is it given in meningococcal vaccine? Is it given or not given?
Not
There
in
is
the
mentioned as to be given in endemic areas.
Is in epidemic area. Therefore, if a person comes to you in Trivandrum and tells you, doctor, should I take meningococcal vaccine? What will be your opinion on that? My question to you is, what will be the opinion on that? Gopika, what's your opinion? Doesn't matter if it is your daughter's opinion also. Give your opinion.
Sorry, sir, I thought it was about the vaccine.
What's it? Should it be given or not given? Okay. Now let's go through it again. Okay. Okay, read it. Now read it. Majida, read it.
Quadrivalent meningococcal conjugate vaccines. A quadrivalent meningococcal conjugate vaccine using diphtheria toxin as carrier protein, it is Menectra Sanofi, administered as one dose, as is licensed for individuals 2 to 55 years of age. A 2-dose series of this vaccine is licensed for use in children aged 9 to 23 months.
Menactra is available, quadrivalent, 9 to 23 months, 2 dose. Okay. Second, yeah.
Second, quadrivalent vaccine conjugated to CRM 197, Menova Glaxo. In some countries, this vaccine is licensed for individuals 2 to 55 years of age.
All right. Now, if you look at the IAP, of course, it's not there in universal immunization program. Now, if you look at IAP, sorry. If you look at IAP, the meningococcal vaccine comes under blue. That is vaccination in special situation. They are advising 2 doses at 1 and this one. Okay, 3 months apart. Is it not? They said 3 months apart. Am I right? 2 doses, 1 dose, 2 dose series as well. License up to children 9 to 2 months. They are not written dose interval. Let's read it. Indian Academy of Pediatrics. Read the whole thing.
Indian Academy of Pediatric recommendation on dosage in different categories. The IAP now recommends the use of meningococcal vaccines in different categories as per following description. During disease outbreaks, due to the limited efficacy of polysaccharide vaccines in children less than 2 years of age, conjugate vaccine should be used for protection of those aged 12 to 24 months, particularly for Meningococcal disease. Since majority of documented outbreaks in India are caused by Men-A, monovalent meningococcal vaccine like PSATT should be employed in mass vaccination. Vaccination of persons with high-risk conditions or situations are children with the terminal component deficiencies. A 2-dose primary series of meningococcal vaccine administered 8 to 12 weeks apart is recommended for person aged 24 months through 55 years with persistent deficiencies of the late complement component pathway. A booster dose should be administered every 5 years. Children who receive the primary series before their 7th birthday should receive the first booster dose in 3 years and subsequent doses every 5 years. And children with functional or anatomic asplenia, hyposplenia, including sickle cell disease, administer 2 primary doses of either meningococcal vaccine with at least 8 weeks between doses of individual aged 24 months through 55 years. Vaccination should ideally be started 2 weeks prior to the splenectomy. Person with human immunodeficiency virus administer 2 doses at least 8 weeks interval. Laboratory personnel and healthcare workers who are exposed routinely to Neisseria meningitidis in solutions that may be aerosolized should be considered for vaccination. A single dose of meningococcal vaccine is recommended. A booster dose should be administered every 5 years if exposure is ongoing. Adjunct to chemoprophylaxis in close contact of patient with meningococcal disease, that is healthcare workers in contact with secretion, household contacts, and daycare contacts, single dose of appropriate group of meningococcal vaccine is recommended.
Okay. 1 minute. All right. Now, okay, read what has come up.
The most cost-effective strategy was routine vaccination of children at 12 months of age, combined with a catch-up campaign for all children and adolescents less than 18 years of age.
All right. Now, Indian Academy, see what it means is routinely, Indian Academy of Pediatrics is not advising this. But my question to you, will you advise or will you talk to your patient or not? Is there any point in talking to the patient about meningococcal vaccine? Okay, can you say that? Anyway, read
in
it.
high-risk
Yeah.
patients.
High-risk patients, a normal patient who come to you and say, Doctor, should I take meningococcal vaccine? Or or even today, suppose Gopika's daughter, should you take it or not, Gopika? What do you say? Will you take it or not?
If you are planning for traveling,
Okay, that's only for traveling. Okay, otherwise, Otherwise, what you say? Paris left and Anju, Ashwati came, I think. Ashwati is as usual, only on. Ashwati, you are there?
Yes, sir.
Finally, what happened to you? Why you are not logging in on time? Hello?
Yes, sir.
Okay. Well, I said 3 to 5, you people couldn't come. Now I made 7 to 9. It is not much of a change. Now you can't blame the call. Now my question, these are fundamental questions. People will come to you and ask you. Even Gobika will have an answer question to yourself. But you will have to ask the question to yourself. Well, you don't give it. Why? Because IAP in his wisdom has not advised for normal people. But will you ever give it? Well, the meningococcal disease, you have a vaccine which can prevent it. And meningococcal is one disease which can kill even an adult in a question of few hours. This is more common actually in Europe, especially in UK. Children go in the morning with fever, adults go in the morning with fever, they come back, they are dead in the night. Now, I'll tell you one thing, that when I was in the Gulf, one incident always sounds very great to me. One patient came to the emergency in our hospital, came to our ward and said, my friend, my brother went to the local primary health center in fever today morning. And the night he died, when he woke up, he was not rising. That was the history. And he said, can you do anything? I am very afraid now. Can you do anything for me? The medical officer in charge at the time, he's an adult. See, even then he called me and said, is it possible that anything can be the reason? Then I told him it was at that time, Hajj pilgrims were not given meningococcal vaccine. Has anybody gone for Hajj from his family? He said, I don't know. I said, if the other fellow had gone or anybody else has gone from the family, it could be meningococcal. And I put the phone down. By evening, the medical officer in charge called me back and said that the relative had gone to Hajj and come back 2 or 3 days ago. He had a fever, but he's all right now. But the other brother died. Then I said, ask him to come immediately and give him a dose of injection penicillin. That's the usual thing that is done. But your vaccine is not available at that time. They took the ambulance. Can you imagine? They took the ambulance and went to his house, and he was in shock. They brought him to the hospital, and he was revived. Remember, that is the urgency of meningococcal disease. Therefore, we have a vaccine. It's a disease which can kill in hours. And it usually occurs in epidemics more than endemics. Therefore, whenever there are 1 or 2 cases anywhere, if you find anywhere in Kerala, some child dies, and when we were students, we used to get a lot of cases of meningococcal, let me tell you. And then you become panic spreads. The vaccine is not available because suddenly all the vaccines will be given. Therefore, in that way, I would say that even for normal children, it's better to give. But it is the individual decision. Okay, now read what is coming up in this. What is it?
Sir,
Yeah, can you tell me? Anju,
sir, recently I had a similar incident, sir. A child in a school that they went to a hospital, only fever was there, and within 24 hours, he developed the rashes, the typical rashes of the meningococcus, and they could not do anything and all. And in foreign countries, meningococcal vaccine is routinely given also, sir. That was all, sir.
Yeah, very good. Actually, in Britain, meningococcus is a major death, 9 to 10 deaths. And I will tell you as it goes along. Can read the whole sentence now here. We have some time today. Read it. Yeah. One of you read. Ashwati, read.
IAP recommendations on dosage in different categories. International travelers, students going for study abroad. Some institutions have policies requiring vaccination against meningococcal disease as a condition of enrollment. That is mandatory in most universities in the USA. Persons aged less than or equal to 21 years should have documentation of receipt of a meningococcal vaccination not more than 5 years before enrollment. In the US, the ACIP recommends routine vaccination of all adolescents with a single dose of meningococcal vaccine for at age 11 to 12 years, followed by a booster dose at age 16 years. For Hajj pilgrims, vaccination in the 3 years before the date of travel is required for all travelers to Mecca during the annual Hajj.
Read the rest.
So 1 minute, sir.
What happened?
Okay. The quadrivalent vaccine is preferred for Hajj pilgrims and international travelers as it provides added protection against emerging W135 and Y disease in these areas. Travelers to countries in the African meningitis belt, a single dose of monovalent or quadrivalent vaccine is recommended. Conjugate vaccine is preferred to polysaccharide vaccine. A booster dose of meningococcal vaccine is needed if the last dose was administered 5 or more years previously.
Let me tell you a few things here because it may not come up again. The commonest cause of an epidemic is meningococcal A. Kills hundreds and thousands of children across Africa every year after year. Meningococcal A vaccine is manufactured in a mass scale in one country, that is India. Serum Institute has meningococcal A vaccine, and even Lancet and even the Western press has said this impact extraordinary because it has caused such an impact in African countries. There's no doubt. But the funny thing is, meningococcal A vaccine is not available in India. We don't know the reason. Probably here only quadrivalent vaccines are available. And till recently, I'm not too sure right now. Therefore, quadrivalent vaccines are better. People going to Hajj, W135 and Y disease are common. Therefore, you have to give the quadrivalent vaccine. Now, people going to UK, there's a problem. In UK, meningococcal B is also common. And meningococcal B vaccine is not available here. It is one of the future vaccine. Actually, the vaccine has been developed and is being given in UK. It's a very costly vaccine, I think. Therefore, it is not. Therefore, if you are taking your children to UK, like some of our colleagues are going to go with their children, of course, when you go there, they will complete the immunization there. It is important to take the meningococcal B vaccine there. So these are important things. Will you give meningococcal vaccine? Plus or minus, but it depends on how you look at it. Okay. Now, if you look at the Indian Academy of Immunization for adolescents or catch-up, there is no meningococcal vaccine. Okay. Remember this. You will have to read it because one of the commonest topics that is asked in the examination is adolescent vaccination. Therefore, they can't ask adult vaccination. By the way, Dr. Anju, I would like to tell you, I have put it up in the IAP also. There is a book, Adult Vaccination, which is given by the Indian government, which I think is better written than the IAP book of immunization. Beautifully given. I put it up in the IAP as well as IMA. You should read it. And
Okay.
it is there. It is the link is there in that. Now, can you read this? This is because it is written for catch-up, but this is the normal immunization for adolescents also. Therefore, if you are asked a short note of adolescent, what are the vaccination you will give in adolescents? You can read it. Okay.
In IAP Advisory Committee on Vaccines and Immunization Practices recommended vaccines in adolescents for catch-up. The vaccine MMR schedule is 2 doses at 4 to 8 weeks of interval. Then hepatitis B, 3 doses at 0, 1 and 6 months. Hepatitis A, 2 doses at 0 and 6 months. Prior check for anti-HIV IgG may be cost-effective in children of age more than 10 years. Typhoid conjugated vaccine, single dose. Varicella, 2 doses at 4 to 8 weeks of interval. HPV vaccine, 9 to 14 years boys and girls, 2 doses 6 months apart. And 15 years or older girls and women, a 4-valent HPV vaccine at 0, 2 and 6 months. Then 9-valent HPV vaccine, 15 to 26 years at 0, 2, and 6 months.
So remember this. First remember what are the vaccines given in adolescents. Catch up if they have not given before. MMR has to be given. Previously vaccinated only 1 dose, otherwise 2 doses. Hepatitis B, okay, has to be given. Hepatitis A has to be given. Typhoid has to be given. Varicella is given in adolescents, okay. In adult vaccination, they are not telling that. HPV has to be given. Now remember what is not there. BCG. What's the upper age limit for BCG, Dr. Majida?
1 year, sir.
BCG up to 5 years according to IAP, if I remember rightly. Can check it. OPV 5 years. Pneumococcal vaccine. Normal immunocompetent children. What is the upper age limit for giving?
5 years, sir.
5 years. Very good. What other vaccine are we giving? Hepatitis B. B is already there here. And what other vaccine are we giving in younger age? MMR is there. And then what is not given here? Something is not given here. That's what I find. Can you tell me what is not given here, Dr. Anju? Can you tell? See, even adults, I get most of the calls from adult physicians and gynecologists on vaccination in adults to me. But if a 15-year-old child comes, what is not given in this? Surprisingly to me.
No, sir. Toxoid.
Any vaccine which they have missed, the Indian Academy of Pediatrics, they do advise somewhere else. This often happens. The right hand doesn't know what the left hand does.
TDAP.
Yeah, very good. TDAP.
Is it TDAP?
See, they are advising TDAP at 10 years, 1 dose TDAP. After that, every 10 years, they are advising either TD or TDAP. If you can afford, you can give TDAP. But it's not necessary you can give TD. But for all pregnant women, only at least 1 dose of TDAP. Therefore, TDAP is missing in this catch-up immunization. If you are giving, if a 13-year-old child comes and says, I have never taken any immunization, the first dose will be TDAP. 6 weeks, it can be TDAP, and the 6 months can be TDAP. But if they cannot afford, TD will be okay. But TDAP can also be given. Somehow that is missing. Okay. Now, can you read pneumococcal vaccine?
Pneumococcal vaccines, pneumococcal conjugate vaccine and pneumococcal polysaccharide vaccine both are used in certain high-risk group of children. A single dose of PCV may be administered to children aged 6 years through 18 years who have anatomic or functional asplenia, human immunodeficiency syndrome infection, or other immunocompromising condition, cochlear implant, or cerebral spinal fluid leak. Administer PPSV at least 8 weeks after the last dose of PCV to children aged 2 years or older with certain underlying medical conditions, including a cochlear implant. A single revaccination of polysaccharide vaccine should be administered after 5 years to children with anatomic or functional asplenia or an immunocompromising condition.
Okay, they are not given for normal children above. They are certain high-risk group. Remember, cochlear implant is a very important indication. Just imagine you have a child with cochlear implant, 10 lakhs, 20 lakhs, you would have done. He develops a pneumococcal otitis and out goes the cochlear implant. Therefore, you must be very careful in these things. And nowadays, you have PCV 15, PCV 20, PCV 24 is coming. In Western countries, already PCV 15 has become the PCV 14 is being given in India, but it's a useless vaccine. Let me be very frank about it. It is less effective than PCV 10, but that's a different matter. But when PCV 20 comes about, there will be a question whether we have to continue giving pneumococcal polysaccharide vaccine because it's less effective than that. In pneumococcal polysaccharide vaccine, you give 1 dose, and immunocompromised, you may at 2 years, you may give 1 more dose at 5 years. But the immunity lasts only 5 years, but you don't give, say, more doses. Can you say why, Doctor? I wanted to say this before. Gopika, can you say why it is like that? Increasing doses of pneumococcal polysaccharide causes what is known as hyporesponsiveness. Actually, the antibody level goes down. Therefore, you don't give. But meningococcal vaccine also, I think typhoid vaccine also, there is a polysaccharide vaccine. You will have to give it every 3 years or something, they have written. There is no hyporesponsiveness in that. Therefore, these are mild symptoms. Now you come to meningococcal vaccine. Remember, read this, please.
Meningococcal vaccine recommended only for certain high-risk group of children during outbreaks, children residing in endemic zones, and international travelers, including students going for study abroad and travelers to Hajj in sub-Saharan Africa. Special situations are anatomic or functional asplenia, including sickle cell disease.
Only read the headline. Okay.
Okay. Special situations, then after primary immunization, one booster every 5 years in cases of persistent risk such as asplenia. Children for whom boosters are recommended because of an ongoing increased risk of meningococcal disease. Example, those with complement deficiency, HIV or asplenia, follow the booster schedule for persons at increased risk. Children for whom boosters are not recommended, example, a healthy child who received a single dose for travel to a country where meningococcal disease is endemic, administer MenACWY according to the recommended adolescent schedule with dose 1 at age 11 to 12 years and dose 2 at age 16 years.
Now, what you should remember always is you should know what the IAP says. The IAP meningococcal disease, 9 to 12 month, 2 doses, and vaccination special situation right up to 18 years. Okay. It is not given only in special situation. It is not recommended. It's not in yellow. That means normal children, they are not advising. Okay. Now, if you look at if you continue with the adolescent vaccination, again, okay, what are the adolescent vaccine that is advised? That is another big chapter. Previously, we looked at adolescents catch-up, okay? Therefore, there are 2 types of adolescent vaccination. Catch-up vaccination, the others who had already been given hepatitis B and others. Regularly, what is the catch-up vaccination? There are only 2 regular vaccines who have been immunized before, okay? Read it.
In adolescents 11 to 18 years, vaccines Tdap or TD schedule is 10 years, then HPV vaccine 9 years, COVID vaccine 12 years onwards. Tdap preferred to TD.
Yeah, okay.
Followed by repeat TD every 10 years.
Okay, there is a problem. Why don't we give TDAP every 10 years? They are in between. They are writing TDAP can be every 10 years. What's the government policy of giving TDAP? Any idea? If you go to the Takad Hospital, Trivandrum, what will they tell you about the vaccination? My question. Only up to 5 years. I don't think they say about 10 years. Definitely every 10 years, they don't advise vaccine. Because if you want to give a vaccine at 10 years, it has to be TDAP. You can't give, TD. You can give TD if you want. But TDAP is very costly, 1,200 rupees, not available in the private. But the IAP says every 10 years, you give TDAP. If you are not able to give, at least give TD. All right. And special circumstances, Japanese encephalitis, the dose is up to 15 years. Okay. But the upper age limit of which they say is 15 years. Remember, in adolescent special circumstance, flu, 1 dose every year. For senior citizen above 50, it is 1 dose every year. But children above 5 years, only for special circumstances. Minimum age 2 doses 5 years apart. The only 2 doses are given because of the hypo-responsiveness. Rabies vaccine, of course, that's a different matter. Can you read it now?
The Advisory Committee on Immunization Practice in 2018 concluded that due to higher cost of Tdap relative to Td and uncertainty about the impact of multiple Tdap doses on pertussis control and transmission, evidence appeared to be insufficient to preferentially recommend Tdap to replace Td. There is no advantage in replacing Td with Tdap for the
Decennial. Yeah.
decennial TD booster, tetanus prophylaxis for wound management, and for additional required doses in the catch-up immunization schedule if a person has received at least one Tdap dose.
Therefore, Majida, the importance of this is you go to see a patient with wound. He's 12 years old. He has not received Tdap at 10 years. You can say better give Tdap. If he has received Tdap, advise them only TD. Okay, this is what the this one says. Very important. See, as you read, you must imbibe the matter behind it and transfer it into your practice. That's what is important. Okay, read it.
Catch-up immunization recommendations in adolescents, children and adolescents, that is 7 to 18 years. Children and adolescents aged 7 years and older, and adults who have never received containing vaccines or whose vaccination history is unknown should receive the 3-dose series. In this situation, Tdap for dose 1 followed 4 weeks later by Td or Tdap for dose 2, followed at least 6 months later by Td or Tdap for dose 3. Following the primary series, booster dose of Td or Tdap should be given every 10 years thereafter. The vaccination series does not need to be restarted for those with incomplete DTaP or wholesale pertussis DT history, regardless of the time that has elapsed between doses. Children aged 7 to 9 years, who receive a dose of Tdap as part of catch-up series, an adolescent Tdap dose should be administered at age 11 to 12 years. A Tdap dose is administered in children 10 years or older. It may count as the adolescent Tdap dose.
Okay, there are two things very important to remember. If you give two Tdap 1 dose, followed by 4 weeks later, everywhere else it is written TD like that. You can give Tdap if they can afford. There's no problem. It is given in the Purple Book of Immunization. I think it is from the WHO itself. Okay, and the rest, I think, is self-explanatory. Up to 7 years. 7 years means completed 7 years. You can give wholesale vaccine, DTWP or DTAP. But once you have completed 7 years, you entered. Remember, all vaccination. When you say 3 months, completed 3 months. That means 90 days. When you say 7 years, completed 7 years. Remember that. Therefore, then every people would say you give Tdap only once at 10 years. Here alone, it is clearly written. You can give Tdap every 10 years also, if the patient can afford. Okay, TD or Tdap should be given. It's given in the IP Purple Book. Okay. Catch-up immunization, can you read? Yeah.
DTaP and wholesale pertussis is not indicated for children aged older than 7 years. If DT acellular pertussis and DT wholesale pertussis is administered inadvertently to an incompletely vaccinated child aged 7 to 9 years, this dose should count as the Tdap dose of the catch-up series, and the child should receive an adolescent Tdap dose at age 11 to 12 years. DT acellular pertussis and DT wholesale pertussis is administered inadvertently to a person aged 10 years or older. This dose should count as the adolescent Tdap dose routinely administered at age 11 to 12 years. In pregnant women, to prevent neonatal tetanus, pregnant women who have completed the childhood schedule should receive a dose of Tdap. Incompletely vaccinated or unvaccinated women should receive at least 2 doses, of which one should be Tdap. If more than 1 dose is needed, either TD or Tdap may be used. The 3-dose primary series should be completed at the recommended intervals of 0, 1, 6 months in unvaccinated.
Well, now you must understand. I will ask you a simple question. What's the difference between DTAP or DTWP and TDAP? What's the difference? What is the difference between TDAP and DTWP? Gopika. Gopika ran away or what? Gopika ran away. Faris, can you say? Visiting consultant, can you say? Ashwati, can you say?
Cellular.
Ashwati,
Yes,
Yeah.
sir.
what's the difference?
Cellular and wholesale.
This is SLR vaccine. This is
Efficacy and
wholesale.
adverse effects.
Yeah, what is the
Uh,
difference between TDAP vaccine and DTAP vaccine?
This wholesale is more painful.
Wholesale, I'm not
Also.
asking between these two. I'm not asking between wholesale vaccine and DTaP vaccine. I'm asking the difference. They say above 7 years, you can give only TDAP vaccine. TDAP is what's the difference between this and this. This also is DTAP. This also contains DTAP. What's the difference? ഇത് രാമായണം മുഴുവൻ കഴിഞ്ഞ് സീതയും ലക്ഷ്മണൻ ആരാന്ന് രാമനെ ആരാന്ന് പറഞ്ഞ പോലെ ആയിപ്പോയി. ഫാരിസ്, വാട്ട് യു സേ? Anyway,
the dosage of antigen, the amount of antigen varies between these two.
varies, which is how it is varies. See, here the only capital is T. Okay, here also. Therefore, the tetanus antigen is same. The D is small letter. Here it is big letter. The D, the dose of the diphtheria toxin is very much less. Of course, it is AP vaccine. No longer wholesale vaccine is used above 7 years. So I thought you knew about it. But TDAP, when we say the dose of diphtheria toxin is much lesser. We use a much lesser vaccine because the side effects are more after 7 years. This has something been here. Pregnant women, we have discussed this 100 times. Only thing I would like to tell you is that there is a tendency for in the Western countries not to give tetanus antenatally. The mother has already received 6 doses of tetanus in her life. That's the thing. If she has already received 6 doses, no more tetanus is given. But don't say that. It may soon come up here also. Now, the last, I think it's the last, this one.
Catch-up immunization, DTWP, DTAP, recommendations for adolescent and adults, immunity against pertussis following primary or booster WP or AP vaccination range over the next 4 to 12 years. The Academy therefore recommends offering TDAP vaccine instead of TD or TT vaccine to all children, adolescents or adults in the schedule discussed below. In those children who have received all 3 primary and the 2 booster doses of DTWP or DTAP, TDAP should be administered as a single dose at the age of 10 to 11 years. Catch-up vaccination is recommended till the age of 18 years. Persons aged 7 years through 10 years who are not fully immunized with the childhood DTWP or DTAP vaccine series should receive TDAP vaccine as the first dose in the catch-up series. If additional doses are needed, TD vaccine should be used. For persons aged 7 to 10 years who receive a dose of TDAP as part of the catch-up series, an adolescent TDAP vaccine dose should be administered at age 11 to 12 years.
So what they say is the immunity against pertussis wanes, okay, over 4 to 12 years. The Academy therefore recommends offering TDAP vaccine as TD to all children and adolescents in the schedule listed below. Very important. Received all the primary and 2 booster dose of should be as a single dose at the age of 10 to 11 years. Catch-up recommendation is stage 18. Okay, prolonged 10 you are not fully immunized. Now, what they don't say is single dose 10 to 11 years. What about at 20 years? What about at 30 years? Now, they say TDAP or TD can be used. Okay, that's what they have told before. Now, is it not better if it wanes in 4 to 12 years? Is it not better to keep TDAP rather than TD? If I tell that is better, What do you say, Anju? Would it be better? Is it important that you prevent whooping cough in adults? Is there whooping cough in adults? Is it a problem? We know that pertussis is a problem younger age. Yeah.
I think it should be done, sir.
Why?
I think it should be done, actually. I am not sure.
The problem is they say in Western countries, wherever there has
don't
been
know.
a cough more than 1 month, even in Western countries, about 10 to 20% of the children, when they are completely evaluated, have pertussis. Okay, they may not have the whoop, they may not have the complication which children develop, and therefore, what is the problem? Therefore, these are whooping cough in adults are not that severe as the patient in the younger age. But what's the problem? The problem is if it is there in the adults, it may happen to the mother, and the mother may transmit it to a child in newborn period, and you can have a higher incidence of newborn whooping cough. Therefore, it is important that we prevent the transmission of whooping cough even in the adults. Though it doesn't kill the adult, it may kill the child, that especially newborn. Therefore, if you have a chance to give TDAP at 20 years, keep giving TDAP. That's my opinion, but that's not the opinion of IAP. It says there's no proof by studies. Well, with that, we come to the end. I would close first the what you call recording, and stopping as stop share, and then recording I will close now. I want to tell a few things.